Sam, you mentioned about the cardiologist, the primary care physician, the nursing staff, and so forth. And where does the family fit into all of this? I think they would also be key players in all of this one.
Absolutely. I think they're pivotal. They're right in the center of all of this because that involves, it's a multidisciplinary approach. And the first thing we tell everybody is, where's your family? We ask the patient, do you have any family? Can we have them involved in this? Because they can be very influential in adjusting not only dietary changes or implementing lifestyle changes, activity changes, and smoking and alcohol, limitation or cessation. Those are like critical points. So if you don't, the patient alone probably is already given in because they've already accepted the fact that they've got congestive heart failure and they're on their way to, either recovery from medications or, progress of chronic disease, et cetera, as Anjali had alluded to. But if the family intervenes early and early enough, I think all of these things can be prevented so we don't have issues regarding medications or other changes that we talked about.
Great.
Yeah, if I may chip in, it's so true, Sam. It's very important because if someone's trying to quit smoking and their family member, spouse, or somebody is smoking, very difficult for them to get off.
Right.
If the wife is cooking and she's putting salt, the husband has no chance of going on a low salt diet. If everybody in the house is having high fat diet, how long are you going to survive on salads? People try to get disciplined, but there is, birds of a feather will flock together. If the whole house is flocking in one way, very difficult. So social support is very important. In fact, when I was at Stanford and they used to do the initial intake for the patients referred for the transplant program for congestive heart failure transplant consideration, social support and family is one of the big questionnaires. And there is a special person assigned to see in the congestive heart failure clinic to make sure that that there's enough social support, and then the nurse actually has constant contact with them every single day in the beginning, and then it becomes once a week, then it becomes once a month. But social support is a very important, families have to do it together.
What kind of telemedicine can be incorporated?
Yeah. Anybody who has congestive heart failure needs really ongoing care. You cannot just say, I'll see you in a year, or take an aspirin and I'll call me a year later. You can't. It has to be a constant, it's a lifestyle. We call it TLC, therapeutic lifestyle change, in which you have to do a lot of changes and you have to follow the lot of parameters like Mr. Bobra has just said. So what do we do with our patients once they get discharged? The first thing we do is to make sure that we have a telephone conversation with them within a week. I give all the CHF patients my cell number because I don't want them decompensating and showing up in the emergency room. I tell them my goal here is to keep you out of the emergency room and out of the hospital. So please watch your diet. Please be compliant with your medicines. If your medicines are getting over, call the doctor a week in advance. Don't call me to say I ran out of it yesterday. And if every single day they have to keep their blood pressure, their pulse, their weight. There's a record that we actually have a congestive heart failure documentation that they take with them. That's a very standard document from ACC/AHA. You can get it. So they do it and they learn that if their body weight every morning without clothes, same time, they go and weigh themselves. If their body weight is more than 4 pounds in 2 days or 4 pounds, actually, I tell them 4 pounds in 1 day. If your weight has changed more than 4 to 5 pounds in 1 day, I want a call that day, not tomorrow, not day after. Because what that usually indicates is not that they have eaten too much, but that they are now retaining water. So I train them, watch for signs of congestive heart failure. If you now cannot lay flat, I need to know. If your legs are swelling more than normal, I need to know. If you have too much bloating, because people don't realize that bloating is not because they ate some bad food. Bloating is because they have water retention, not only outside in the body, but also in their gut. And when that happens, they get bloated, they get full earlier, so they're not eating, they don't get nourishment. And then when they take their medicines, it doesn't absorb. So at that point, they need to come in and get IV medicines so that they can absorb it. So the main things are measure your parameters at home. Now, talking about, and then they go to cardiac rehab. Everybody who's been revascularized goes through cardiac rehab. It is one of the best services provided by Medicare, is that they agree for the 36 sessions of cardiac rehab, where they learn to exercise and improve not the entire cardiovascular functional status. So even the peripheral muscles, when you exercise, you're going to flush out the, you have more circulation, the lactic acid accumulates, your vessels dilate. So everything improves, the vascular tone improves with exercise. So they go for cardiac rehabilitation after revascularization or a heart attack. Now, what you said about heart rate variability is phenomenal, Yoginder. There was a paper in the 1990s, I think it was 96, 97, this article came out, and it's a brilliant article on heart rate variability in patients with congestive heart failure. And it is an individual prognostic indicator of long-term mortality. So if a person has very good heart rate variability, which means they are sitting down, they are 50 beats a minute. They get up, it is 56. They take a deep breath, it slows down. They breathe faster, it goes out. So with the respiratory function and with your functioning, the heart is able to slow down or improve or increase the rate. So it's the variability, the beat to beat variability. People who have heart rate variability, and if you're measuring it, it's phenomenal, Yoginder, because that is an single most individual prognosticator. We don't use it enough in cardiology, we just don't. But it is a beautiful indicator. If somebody does not have heart rate variability, it's a bad sign. It's a bad sign, and they have high morbidity and they have low life expectancy and high mortality. So heart rate variability is brilliant. And since this is the CWC, I am, if I may take a minute, very important. One of the things that you can do to improve your heart rate variability, you can go about it the Indian way, or you can go about it the I'm in the Silicon Valley, I need a gadget way. It's up to you, whatever floats your boat, do it. There is a thing called pranayam. If you do pranayam and you learn to do breath control, you actually decrease your sympathetic tone, and you increase your parasympathetic tone, and your heart rate variability improves. You can make your heart beat faster or slower just by breath control. It is a real science, and there is scientific evidence for this. So you can find a good yogic guru and learn how to do pranayam. And if you want, you can go, there is a place somewhere in the Silicon Valley, it's called Heart Math, like mathematics. You go to Heart Math, they make you sit in front of monitors, they hook you up, and they train you to modulate your heart rate, your blood pressure, your rhythm, and everything. So people who have all kinds of palpitations and things, with Heart Math, with objective biofeedback, can actually improve their heart rate variability.
Pranayam, it's one of the lifestyle modifiers.
It is.
Are there any others that you can employ? And do you know of the actual failure being reversed?
Oh, yes, absolutely. It's actual reversal. It's usually revascularization, long-term management, and lifestyle changes are along. Nothing is in series. all of it is in parallel. You have to do the ABCs. You cannot just dump medications. We haven't spoken enough of medications on this. Heart failure medication is a whole science and art in itself. Patients should be on aspirin if they have coronary artery disease. If they don't, that benefit is really yes, today, not tomorrow. They should be on an ACE inhibitor. And especially in the Indian diaspora, I am presuming there are lots of Indians on this forum. Indians have a lot of diabetes and they have a lot of hypertriglyceridemia, low HDL and high LDL. So in these people with their diabetes, hypertension, hypercholesterolemia, and heart failure, and even in general, you need to have them on aspirin. They should be on an ACE inhibitor. And if they cannot afford an ACE inhibitor because of side effects, because ACE inhibitors are generic, anybody can buy them. They're very, very cheap. If they have side effects, because people can have terrible that kind of a cough and they can't tolerate it, or they can have actual angioedema. So if that's the case, then we put them on angiotensin receptor blockers. And if they can't tolerate that, then they get put on isosorbide plus hydralazine. So there are multiple levels. These medicine reduce the afterload. What that means is if this is the heart pumping into this chamber, the afterload, that this actually becomes easier, so the same weak heart can pump more into that conduit. So you use ACE inhibitors, ARBs, you use beta blockers. It's a mainstay of therapy for congestive heart failure, cardiomyopathy. If it's systolic dysfunction, you use digoxin. You use a diuretic because these people gain weight. If you use diuretic, you have to watch their potassiums and magnesiums very closely. Otherwise, they can have arrhythmias. And then beta blockers I mentioned, and this is what Sam was saying. If you have congestive heart failure, cardiomyopathy, they need to be followed very closely. You give the patients beta blockers, almost 25 to 50% patients will stop taking it, because they get so tired with the congestive heart failure. They're already tired, and beta blockers cut off the adrenaline drive. So it's basically they block the beta receptors. So the person, instead of being like this, is like this. They are tired, they're tired, they're tired. And they get so tired, and in male patients, because of sexual dysfunction with those medicines, they toss them out the window and don't even tell the patient, the doctor. So we have to have an honest conversation with the patient. These are the medicines you'll be taking. And if these medicines give you these possible common side effects, please come talk to me. We'll find an alternative. Do not stop the medicines by yourselves. So medications, very important. Diet, very important. Salt control, important. Low fat diet, right? No saturated fat diet. And then the water reduction in congestive heart failure, cardiomyopathy with hypervolemia, where they have too much water retention, they have to reduce the amount of water they drink. So it's a really terrible situation for the patients. Think about it. They can't have too much water. They can't add salt. They cannot have any tasty, greasy food. They're usually diabetics. They cannot eat sugar. What do they eat? And sometimes they have renal failure with it. Anything that they put in their mouth has potassium, and they have to be careful. So it's very difficult, and you have to work with them. And then exercise. They can do exercise. They can quit smoking. One of the questions that you said in the beginning was about alcohol. And for the longest time, that one study, the Italian study, was a bane of, it was a real problem, because every patient that came, and especially in the Indian community, people would come and say, hey, doc, I have your permission, with 2 glasses in their hands. And the answer, there was nothing we could tell them, because there was one association study that if you drink a glass of wine, you might have low incidence of heart disease. Well, finally, the ACC AHA guidelines a few years ago, about 10 years ago, finally took a stance on it and said that with red wine, there is one study, which is an association study. It is not a double-blinded, randomized, prospective, blinded,
Right, right.
ongoing study. So
But certainly the media got hold of it and
they got a hold of
over-
it. The summary is that if you drink a glass of wine, drink it. But if you think you're going to start drinking to prevent heart disease, don't do it, because it's a very slippery slope. You don't know when one becomes 10 glasses. That's the AHA guideline.
Right. So I take it that this treatment that you outlined is pretty standardized the
It's
world
standard.
over.
It's standard.
You don't have
Yeah,
to live
actually,
in Silicon Valley
wanna-
to get access to
No.
some of the fancy stuff. But by and large, when it comes to diet, medications, and so forth, it's pretty standard.
Yes.
Correct?
Yeah.
So are there any clinical trials specific to the South Asian community that some of these patients with heart failure can subscribe to?
You want
So
Which
to
you're
there's
aware
several.
of?
Yeah, I can just give you a general idea. I know I've been looking at some of the Indian medical journals and some other journals where there's been sporadic data, but overall, I think the consensus still comes from the United States and also from the American Heart Association guidelines and possibly some of the Canadian guidelines. So I think that a lot of this has been double-blinded, as Anjali had said, and so we adopt heart failure management based on US standards.
Great. So you may have alluded to this, but there's one question from one of our viewers about a lot of talk about reversal of blockages by diet and exercise. I know you made a mention of it. Is there a way of checking it non-invasively to
So
see
maybe
if there's some
I'll
impact
jump
from
right
your
in.
lifestyle?
I'll jump right into this, and then I'm going to pass it on to Anjali because she has a little bit of a different perspective. But basically, how we check at this point, I mean, there's objective ways, and the single best way, of course, is non-invasive way is a stress echocardiography procedure or a stress test. That I think is garden variety. You know, if you have a doubt, treadmill. That's the number one thing. Besides doing an EKG, which is similar to just taking a photograph for a 3-second, evaluation. But if you can functionally test them, that is the one best way to follow not only heart failure, but also to follow angina or angina equivalent symptoms as they may occur from partially blocked arteries or, the other issues about plaque stabilization, which does occur with statins, and that's been well known. But I think Anjali will tell you more about CCTA and so on and so forth, because there's other ways to measure coronary calcification and things like that. And that's been well written up.
Okay.
There could
All
be
right.
a whole session on this one.
No, I'll make it very brief. I think my perspective is exactly the same as Dr. Suri's. We practice evidence-based medicine. You can do a coronary CTA, which is the calcium, and you can do calcium scoring. Calcium scoring is going to give you radiation without enough answers. If you get a calcium score that is high, you could have deposition of the calcium in the inside of the artery, outside of the artery. You don't know the significance of it. You end up doing a stress test. So I spare all my patients the calcium scoring. I don't do it. I actually do exactly what Sam does. It's evidence-based medicine. You do a stress test. If the ECG is normal, you do a plain old stress test. If the ECG is abnormal or the patient has some other issues, you do a stress echo. And if the patient cannot run on the treadmill, you do a thallium perfusion study. This is called a cardiovascular functional study. It gives you the answer that even if a patient has a blockage, what is the significance of that blockage? If you have 40% blockage, but you pass the stress test, you don't need anything further. What you need is prevention. You need your statins, you need your aspirin, you need your blood pressure control, and you need your diabetes control. But if the stress test is abnormal, then they need the angiogram. A lot of time patients come and say, my family member has it, just do an angiogram. And the answer to them is no. You do a cardiovascular functional study exactly as Sam Suri has said, you do it exactly like that. If that test is normal, then you don't get an angiogram. An angiogram is a test we do all the time, but it is an invasive test. And any invasive test, you have to be careful that the risks have to be low and the benefits have to be high. But if the risk is even 0.001%, you don't do it unless you benefits far outweigh it. So functional study, Sam, I'm
Right.
with you.
Terrific. I have to ask
Thank
you,
you.
I have to ask you both this question since we're in the midst of this pandemic still. What is the effect of a COVID infection on the heart, and how lasting are the effects of this vis-a-vis heart failure and recovery from this? It is especially pertinent because there is still a fair segment of the population that doesn't believe in vaccinating and doesn't mind getting the infection. Does it leave a significant deficit as far as the heart is concerned?
So I'll dive into this one, Anjali, because I did actually give a talk on this about the last time we were here on COVID and heart disease. So I'll just bring up the salient 5 or 6 points. First, COVID affects every organ. We know that. Second, besides affecting the lungs, it definitely affects the heart in a big way, directly onto the myocardial cells, which is basically the actual muscle cells, and then indirectly by causing inflammation around the heart as well. And then it also does influence and make heart failure worse in a lot of patients that already have coexisting disease. And then 4 and 5, it also can propagate in many patients who have the risk of developing cardiac arrhythmias. The arrhythmias get worse. And then lastly, their lifestyle changes that sort of get hurt as well because of the declining overall health from COVID, fatigue, and so on and so forth. So those are the 5 salient points in this. And it also increases blood clot formation, which is very serious. Deep vein blood clots, and then also superficial vein clots and clots within the heart.
This is even if you're vaccinated.
Yes, vaxxed or no vaxxed. I mean, the risk is still there, and that's why we have to be careful.
Absolutely. Thank you. Any closing comments, Anjali?
For the COVID thing, yes, like Sam has put it very eloquently in 5 points. One of the issues is that so initially in the first 2-3 months of COVID, the concern was that the cause of death was cardiorespiratory, and in the heart, they said there's myocarditis, there is an increased number of thrombosis, so there is a huge number of heart attacks, and then arrhythmias. But over time, because at that point, nobody knew what was going on. And, last year, there have been 120 or 150,000 articles on COVID. It's like my experience, my anecdote, it doesn't work that way. So initially, CDC came out that there is more death with myocarditis, increased thrombus and heart attacks, and ventricular arrhythmias. What has panned out is a few months into the COVID pandemic in 2020, American Heart Association and JACC actually came out and said, where have the acute heart attacks gone away? Because the actual ST elevation MI numbers actually came down. So if they are coming down on the one hand, or on the other hand, you're saying there is more thrombosis and more heart attacks, it doesn't match. So that data is there's 2 separate kinds of data sets over there. Time will tell us exactly what it is. But myocarditis is a real problem with viral infections, and mRNA will be found in them. I haven't seen too many studies about it. And I heard about studies in which people who had COVID, normal young people, and this is the really scary part, they didn't have bad COVID. These are athletes. And months later, they are coming with cardiomyopathies. So I'm actually screening a whole set of patients who had COVID. We're doing echocardiograms on them, and we are actually collecting data to see where it goes. So far, we've not found any cardiomyopathy 4 to 6 months to a year after COVID, but our cohort is very small, but it is a real fear.